Hello, everyone, and welcome to our second module on antiarrhythmic drugs. Shown on this slide is the Vaughan-Williams classification system for antiarrhythmic medications. I talk about the Vaughan-Williams system in the first video on antiarrhythmic drugs, but in that first video, I talked about all the class 1 antiarrhythmic agents. So in this video, I'm going to focus on the other three groups, the class 3 drugs, the class 2, and the class 4 drugs. So let's start with the class 3 drugs because they're the trickiest. So examples of class 3 antiarrhythmic drugs include amiodarone, also sotalol, dofetilide, and ibutylide. And these drugs, because they're in class 3, block potassium channels. So that delays repolarization of myocytes. So you get a switch from the black action potential here to something like the blue one here. This is really not going to change the QRS complex much. That's affected by phase 0 here, which is the same in the black and the blue action potential, but it is going to increase the QT interval. That's what most of the class 3 drugs do, is increase the QT interval, and therefore they can potentially cause the arrhythmia torsade de pointes. And then these drugs, because they prolong the action potential duration, they're going to increase the effective refractory period and the overall action potential duration. Let's start by talking about amiodarone. And if you were only to learn one class 3 antiarrhythmic drug, amiodarone is the drug I would tell you to learn. It has lots of adverse effects that are easy to write test questions about, and it's also very commonly used in clinical practice. So amiodarone is a class 3 drug, so like all class 3 drugs, it blocks potassium channels, and it can prolong the QT interval. However, it usually doesn't prolong the QT interval very much, and it's famous for having the lowest incidence of torsade de pointes of all the class 3 antiarrhythmic drugs. Now, a confusing thing about amiodarone is that even though it's a class 3 drug that blocks potassium channels, it also has class 1, 2, and 4 effects. So it prolongs the QRS complex in some instances, like the class 1 drugs, and it can also slow the heart rate and delay AV conduction, like the class 2 and 4 drugs. Beyond these things, amiodarone is commonly used in clinical practice. As I said, that's because it's highly effective. It's very good at suppressing atrial fibrillation and keeping patients in sinus rhythm. It's also very good at suppressing ventricular tachycardia. Amiodarone is highly lipid soluble, and if you know that, it's easy to remember that it accumulates in lots of different tissues in the body, and this will be important later when we talk about adverse effects, though it accumulates in the liver, in the lungs, in the skin, and in many other tissues. It also has a very long half-life of about 58 days. So once you achieve steady state with dosing of amiodarone, there's a very long time required for the drug to wash out from the body. If you stop amiodarone in a patient who's taking it and has been taking it for a while, it's going to be very long until all the amiodarone has left their body. It's excreted in the biliary system, and so that makes it safe in kidney disease. All right, now we're going to talk about the side effects of amiodarone. But one thing to know about this probably won't come up on the step 1 exam, but it's important to know in clinical practice, is that the side effects are all related to accumulation of the drug over time. So they're less likely at lower dosages, and the longer a person has been taking it, the higher the risk becomes. So really, you need to take amiodarone usually for many years in order to develop some of the key side effects of the drug. So we hardly ever put a young patient on amiodarone because if they're going to be on it indefinitely, that's going to be a very high risk of adverse effects. But you will commonly see amiodarone used in older patients, people who are in their 70s or 80s or 90s who need suppression of an arrhythmia, and that's because the likelihood that they're going to develop adverse effects over the remaining years of their life is fairly low. Okay, so now let's get into the side effects. So amiodarone can cause both hyper and hypothyroidism. I talk about this in more detail in videos in the endocrinology section, but you should know that the reason the letters IOD are in the name is because amiodarone contains iodine. You can see its structure here, and it's got iodine molecules, and iodine is part of thyroid hormone. So amiodarone is often taken up by the thyroid gland, and that can lead to hyper or hypothyroidism. It also accumulates in the liver, so it can lead to increased liver function tests. This is usually asymptomatic and very mild, but if it's severe, usually the drug has to be stopped. And then finally, it accumulates in the skin, so it makes patients sensitive to the sun. They easily sunburn, like this person in this image here. And so patients who are put on amiodarone need to know that they have to be careful when going out in the sun. Besides sun sensitivity, there's another adverse effect of amiodarone, but it's much less common. This is a blue-gray discoloration of the skin. This is a picture of a man who has it here. You can see this blue-gray discoloration of the skin on his forehead. This is called the blue man syndrome. It's most prominent in the skin of the face, and it's a very uncommon side effect of amiodarone. And then finally, patients can develop corneal deposits. So amiodarone is secreted by lacrimal glands into your tears, and it can accumulate on the surface of the cornea. And this will give the appearance of little cat whiskers on the cornea. There's an example of it shown right here in this image. If you look carefully, there are little whispers of little lines in the cornea, and that's an effect of amiodarone. Now, this usually does not cause any vision problems. It's seen in patients on chronic therapy, and usually you don't need to take any action if you see this. It's just an expected finding in a person who is taking amiodarone. The most feared side effect of amiodarone is pulmonary fibrosis. This is how patients die from taking this drug. This happens because macrophages take up lipids with amiodarone bound to the lipids. These macrophages are called foamy macrophages. They're filled with amiodarone and phospholipids, and they accumulate in the air spaces. And the classic finding on chest x-ray is a honeycombing pattern like what's shown here. And I talk more about pulmonary fibrosis in videos in the pulmonary section. So wrapping this all up, something you should know for your board exams is that when you're starting a patient on amiodarone, the tests that are usually done are a chest x-ray to serve as a baseline for comparison later if the patient develops symptoms that might be due to amiodarone. Also pulmonary function tests to screen for evidence of restrictive lung disease and fibrosis in the lungs. And then TFTs to make sure the thyroid is normal, and liver function tests also to make sure the liver is normal. Okay, so now let's talk about some of the other class 3 antiarrhythmic drugs, and we'll start by talking about sotalol and dofetilide, which are relatively similar antiarrhythmic drugs. So like all the class 3 drugs, sotalol and dofetilide block potassium channels. And unlike amiodarone, these drugs can significantly prolong the QT interval, and there's a relatively high risk of torsade de pointes. So there's a practical consideration because of this. Patients are often admitted to the hospital when they need to start therapy with one of these drugs. Their heart rhythm is monitored on telemetry, and the QT segment is checked each day. And this is to make sure that they don't develop a markedly prolonged QT interval or any evidence of torsade de pointes. These things usually happen in the first few days on therapy if they're going to happen at all. Now, sotalol ends in a lol, so hopefully you know that that means it has some beta blocking properties, and that's a unique feature of that drug. And the reason these two drugs are relatively popular antiarrhythmic drugs is because you can use them in patients who have cardiomyopathy. They're safe in patients who have a lower ejection fraction, and that's not true for a lot of other antiarrhythmic drugs. And then finally, these two drugs have a special feature called reverse use dependence. So let's talk about what that means now. So to understand reverse use dependence, you need to appreciate that potassium channels fluctuate between 3 different states as myocytes go through their action potential. The channels are open in parts of the action potential like here, they're inactive up here, and then they enter a resting state which persists until the next action potential occurs. And so most of the action of sotalol and dofetilide is in the resting state, and that's what leads to the phenomena of reverse use dependence. So if you look at this bradycardic EKG at the top of the slide here, the areas in blue are when there are no action potentials occurring in myocytes. We know this because the EKG is at baseline between depolarizations and QRS complexes. Down at the bottom is a person with a tachycardic heart rate, and you can see there's much less blue, and that means there's much less time when the potassium channels are in the resting state. So the take-home point here is that when patients are bradycardic, that means there's more opportunity for sotalol and dofetilide to bind to potassium channels, and those drugs are going to have more effect when patients are bradycardic. And so this slide is here just to emphasize that point. Reverse use dependence of sotalol and dofetilide means that the drugs bind more at slower heart rates and bradycardic rhythms. And this has a practical implication. If a patient develops bradycardia when they're on sotalol or dofetilide, the drugs will bind more, and that means the QT interval could prolong, and that means the risk of torsade de pointes could go up. So generally, we don't like to give sotalol and dofetilide to patients who are very bradycardic because we worry that that's more likely to lead to QT prolongation and a risk of torsades. The place where you'll most likely see sotalol and dofetilide used is in patients who have atrial fibrillation. So the typical case is a person who has recurrent episodes of symptomatic atrial fibrillation. They're admitted to the hospital and started on sotalol and dofetilide. Then they have some type of cardioversion to restore sinus rhythm. And because they're on one of these drugs, sinus rhythm will persist, where it was more likely to come back if they hadn't been on one of these antiarrhythmics. And other antiarrhythmics are also used in this manner, drugs like amiodarone, propafenone, or flecainide. It's individualized to the patient which drug you choose, but many are used in this manner to keep patients out of AFib. The last class 3 antiarrhythmic drug is ibutylide. It's not used very commonly. It's an intravenous drug with a half-life of about 2 to 12 hours. The one place you'll sometimes see it used is for what's called a chemical cardioversion. This is a way to terminate arrhythmias without using an electric shock. We often do this for patients in AFib or flutter. So here on the left is a person who's in AFib, and then they have a cardioversion and they're back in sinus. The way this is normally done is with electricity. You use sedation to sedate the patient, deliver an electric shock, patient goes into sinus rhythm, and then they wake up and they can go home. But there is an alternative way to do that where you don't have to use sedation on the patient, and that's where you administer ibutylide. It converts about 70% or so of patients into sinus rhythm, and then you're able to convert them without sedation. Downside is you have to monitor them for about 12 hours to make sure their QT interval doesn't prolong and they don't develop arrhythmias. So for that reason, chemical cardioversion is rarely done and electrical cardioversion is much more popular. Okay, now let's talk about beta blockers, which are class 2 antiarrhythmic drugs. And in contrast to the class 1 and 3 drugs, beta blockers have their main effect on pacemaker cells of the SA and AV node. So the class 1 and 3 drugs generally target the myocyte action potential, which looks like this. It occurs in cells of the atria and the ventricle. In contrast, beta blockers target cells in the SA and AV node. Those have the pacemaker action potential, which looks like this. And beta blockers have two effects that slow the rate of depolarization of the SA node that lowers the heart rate and also cause conduction through the AV node to be prolonged. The first effect is that they decrease the slope of phase 4. So let's talk about what that means. This is phase 4 of the pacemaker action potential, where the voltage is slowly climbing until it reaches threshold, and then you get a depolarization. Well, what beta blockers are going to do is decrease the slope, so it takes longer to reach threshold. That's going to cause less firing of the SA node, and that's going to lower the heart rate. And that's how beta blockers decrease the heart rate. Beta blockers also make this whole process of depolarization and repolarization take longer by prolonging phase 3. That's going to cause conduction to slow down in the AV node. And so those are the two effects of beta blockers, lowering the heart rate and decreasing the rate of conduction of electrical impulses through the AV node. And so on this slide, I've shown two action potentials. The blue represents what might be a normal action potential. The red is one in a person who's on a beta blocker. So notice that the slope of phase 4 has been decreased, so it takes longer to reach threshold. Notice also that phase 3 takes longer, so that the whole action potential takes longer to occur. This is going to lower the heart rate, which you know is one of the effects of beta blockers. It's also going to decrease the conduction velocity through the AV node, and that's going to increase the PR interval. This is a high yield thing to know about beta blockers, that they can make the PR interval longer on EKG. And then I'll finish this video by talking about calcium channel blockers, which are class 4 antiarrhythmic drugs. The two calcium channel blockers used as antiarrhythmics are verapamil and diltiazem. They both block calcium channels found in the pacemaker cells of the SA and AV node in the heart. So phase 0, shown here, this portion of the pacemaker action potential depends on the movement of calcium. So when these drugs block calcium channels, that slows down this phase of the action potential and makes the whole action potential take longer to occur. When that happens in the SA node, when action potentials take longer to occur in the SA node, that will slow the heart rate. And when action potentials take longer to occur in the AV node, that will slow AV node conduction. And so here's a drawing of a normal action potential and the action potential of a person on a calcium channel blocker. The main effect is here in phase 0. It's high yield to know that for your boards. So in the SA node, that's going to slow the rate of depolarization and lower the heart rate. And in the AV node, it's going to decrease conduction velocity and prolong the PR interval on EKG. And so just to make this point very clear, because I think it's very high yield to know for your boards, both beta blockers and calcium channel blockers slow AV node conduction that can prolong the PR interval and also cause some forms of AV block. So shown here at the top is a prolonged PR interval. This is the PR interval here. It's prolonged in the CKG. That's called a type 1 AV block. And you can get that if you're taking a beta blocker or a calcium channel blocker. It's not dangerous, but it's something you'll see on the EKG, a prolonged PR interval. And that's from the slowing of AV node conduction by these drugs. You also can get higher forms of AV block potentially, like this is an example of Wenckebach here, Mobitz type 1, and in rare cases, you can get even higher forms, all from the slowing of AV node conduction. In clinical practice, one of the places where you'll most commonly see beta blockers and calcium channel blockers used is in lowering the ventricular rate in patients who have atrial fibrillation. So many patients who develop AFib have a rapid ventricular response. That means a very fast heart rate, a tachycardic heart rate. That's what's shown in the EKG at the top of the screen here. When the heart rate's going this fast, it's uncomfortable for the patient, and if it persists, the patient can develop a cardiomyopathy. So if you give the patient a beta blocker or a calcium channel blocker, you can rate control them. This means you bring their heart rate down so it's more near the normal range. Usually patients feel better with a slower heart rate, and they're much less likely to develop a cardiomyopathy. And so this is one of the main antiarrhythmic uses of beta blockers and calcium channel blockers. And then finally, beta blockers are often used in patients who have systolic heart failure and cardiomyopathy with a depressed left ventricular ejection fraction. Those patients are at increased risk of sudden cardiac death from arrhythmias like ventricular tachycardia or ventricular fibrillation. So if you give those patients a beta blocker, studies have shown that you improve their mortality. In other words, you make it less likely that they will die from sudden cardiac death from one of these arrhythmias. And so all patients with cardiomyopathy, usually if they don't have a contraindication, they're placed on a beta blocker for its antiarrhythmic properties to make these arrhythmias less likely to occur. And that concludes our second video on antiarrhythmic drugs.